Thank you for the organizing committee for inviting me to this elegant meeting. I hope that you'll wake up, because this is a very frustrating case. It's an old case, so you need to follow my slides. So this is my case. A 60-year-old male, diabetic, hypertensive, dyslipidemic, with chronic renal failure and hemodialysis, and he had frequent chest pain in the last 6 months. His echo ejection fraction was okay, with regional wall motion abnormality in the form of hypokinesia of inferior wall, and the positive dopamine stress echo, it shows there is a positive ischemia in the trajectory of LCX and RCA, all the risk factors as we see. And this is the diagnostic angiogram. You see, there is a totally occluded left main from the ostium. RCA is totally occluded. And if you look here for the vein grafts, all are occluded. And the lima to the LAD, you have a good collaterals to the, this is the lima, connection very good. And there is some collaterals giving retrograde through the LCX and distal RCA. So dual injections, if you look here, you will see there is a good feeling of the circumflex artery and the RCA, and you will see that the only feeding vessel is the lima. If you look for the still pictures, this is the left main, and this is how there is a very tiny channel, and it's totally occluded, and the feeling of the circumflex and OM from the collaterals from the BMAT, LAD, and then the collaterals. Is it medical case? Redo? I think no, because they have a good LAD, lima to the LAD. PCI, it's a very high risk procedure. If you look for the GCO score, it's high. And the hybrid algorithm, yes, we have some try to do antigrade, and then if it's okay, so you can go wire escalation. If not, you can go retrograde. This is the start of the case using XP 3.5 and Lima 6 French guiding catheter, and the fine cross and small trial. First, definitely the microcatheter on one of the cyan blue, and then we go for Fielder XTR and try to connect, and then we change it to the Gaia-3, and we succeed to cross the CTO segment, and then is okay. Now we are confirming that the distal wire is in the OM branch, and then we start a balloon with 2 by 20, and as you see, there is slow flow in the left main and then CX, but it looks okay. And this is different views. And this is a test to see where is the guiding catheter to check. And suddenly the patient has severe chest pain. Shocked. What happened? Definitely there is something, but we don't know where. And everything is off the angio, and then we're looking one for each, and what happened? So this is the CPR started, and then a very slow flow in the lima. And this is, as you know, this is the only feeding artery for all the heart. And we try to go again using a balloon, a lot of dissection also in the lima, as we see. And there is also dissection in the left main OM. And during this CPR, a lot of CPR, try to get some flow, yes, as you see, a lot of dissection, and everything comes out. This is a problem. During CPR, there is no control this on the system, and comes out, and we try to go again. As you see, it's very slow, a lot of dissections, and we want to know what happened, and we want to go out of this problem. And this, try to go cross again, you have some flow, now the patient is more stable, and we got some flow in the distal, and we try to go again, and as you see, there is a dissection in the ostium of the lima, to the, and then the very slow flow in the lima to the LAD. And now we balloon, and then we stent it. And we look here, and then another stent is 3.5 by 36, which has a good flow now, and the patient was stable. And we stent the left main to the OM, and then we use this. There's definitely a slow flow in the distal OM, but this is the lima is okay, the feeding vessels are okay, and we have some flow in the CX, and this patient was put in intra-aortic balloon pump at that time during the procedure, and this patient was referred back home, and the comeback, we did for him the RCA, but I don't want to show the result. Is very good result for the RCA also. So my take-home message, use a contralateral injection if you have a CTO lesions, use to guiding, as all we know, in the feeding vessel and the left system. For any complication can happen, and you can see the distal flow, and definitely you need to precise decision in a post-CABG patient, especially if you have only one feeding graft vessel, with all the collateral vessel, and it's this graft, if something happens, it will, the patient will crash. Thank you.
Excellent, thank you very much.